On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Shoulder Dystocia Strategies for Action. My name is Jessica Oakes, and I will be moderating this program. We welcome any comments or questions. All materials are provided for your educational use. Now I'd like to introduce our speakers for the webinar. Christine Sanchez works as a research scientist for the Patient Safety Authority's Data Science and Research team. She is responsible for utilizing patient safety data combined with relevant literature to develop strategies aimed at improving patient safety in Pennsylvania. Sanchez is also responsible for authoring manuscripts based on the results from this research, which are published in the PSA's peer-reviewed journal, Patient Safety. Anna Thomas is a clinical nurse leader and works as a senior patient safety advisor within ECRI and the ISMP Patient Safety Organization. She serves as a subject matter expert and liaison for PSO members and leads the development of client deliverables and education. As chair of the causal analysis team, she is responsible for data collection and analysis for multiple forms of causal analysis. She provides expert feedback to members on their causal analysis efforts and subsequent action planning, and moderates safe tables along with educational webinars related to causal analysis. None of the planners for this educational activity have relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Christine, I will now turn the program over to you.
Thank you, Jessica. Our objectives today are to recognize the challenges related to shoulder dystocia cases and evidence-based practices to treat and respond to cases of shoulder dystocia. We also want to identify the steps that can be taken after such an event occurs and apply this knowledge to reduce the number of patients harmed as a result of shoulder dystocia. I'm going to talk today about the results from the neonatal serious events report that, excuse me, that was distributed in April of this year that led us to then work with ECRI to review shoulder dystocias more closely using the safe tables and working with the PA facilities. So between 2018 and 2022, the number of serious events reported to the Pennsylvania Patient Safety Reporting System, PACERS, under the neonatal complications subtype increased by 92%. This report aimed to identify potential neonatal injuries or deaths related to labor and delivery and opportunities for prevention and/or management of these complications. To identify relevant event reports, we queried the PACERS database for reports of serious events that occurred between January 1st and December 31st, 2022. For inclusion in this initial data query, we pulled reports that were submitted under the neonatal complication subtype of the complication of procedure treatment test event type, except those with a location in the emergency care area group. We also included reports submitted under the complication of procedure treatment test event type, the error related to procedure treatment test, skin integrity, or other miscellaneous event types, with a location in the obstetrics and gynecology unit, labor and delivery, or surgical services care area groups, and used a free text search that contained at least one keyword describing a neonate and at least one keyword describing a potential complication to get our initial data set. The initial query returned 304 reports, which were manually reviewed to identify relevant events. A relevant event was defined as an event related to labor and delivery that occurred or became apparent during labor and delivery or within 3 hours after birth and resulted in an unanticipated injury or death of a neonate. After reviewing the 304 reports, we identified 169 relevant events. We then decided to supplement the information contained in the PA Pacers reports by developing a 15-question form that was emailed to facilities asking about individual events to get some more information related to labor and delivery. We sent 168 supplemental data forms. One facility had closed from the time that we identified the relevant events and sent out the forms. That's why we sent 168. And after reviewing the information provided in supplemental data forms, we excluded 6 additional reports that did not meet our definition of a relevant event. So the report, the data in the report then reflected 162 event reports to be included in the analysis. We identified 8 labor and delivery event categories. You can see them in the table on this slide. And the most frequently occurring event was shoulder dystocia, described in over 1/3 of the event reports. And you can see that at the top of the table there. We also looked at interventions and outcomes associated with the labor and delivery events. For this webinar, I just pulled the ones that were associated with shoulder dystocia, since that is the focus today. And you can see that we identified outcomes, interventions and outcomes such as respiratory distress in the neonate, or that the neonate required respiratory support, a fracture, glacial plexus injury, unanticipated NICU admission or transfer to another hospital, a hypoxic ischemic injury, death, skin injury, and then we had some that were an other intervention or outcome, and one that we were not able to determine. All 59 shoulder dystocia events involved either normal or high birth weight neonates and occurred more frequently in full and late term deliveries, nearly 73%, than in early and preterm births, with 27% occurring in early and preterm births. We did not find any associations between shoulder dystocia and maternal demographics, other labor and delivery events, or interventions and outcomes. The maternal and neonatal demographics include outcomes like maternal age and the gravity and parity of the mother. Some examples of other labor and delivery events include fetal distress, meconium stained fluids, breech presentation. And some examples of other interventions and outcomes includes those, excuse me, listed in the table in the slide previous. The neonatal complications report concluded that neonatal serious events related to labor and delivery would benefit from further research. And due to the high frequency of shoulder dystocia events, PSA partnered with ECRI and the ISMP Patient Safety Organization to conduct a safe table, a protected environment in which Pennsylvania healthcare professionals had the opportunity to discuss the risk factors, challenges, and mitigation strategies associated with shoulder dystocia. So our next slide is our first polling question for today. And to answer this question, you can feel free to type your response in the chat box. It's a pretty straightforward question for our first one. Has anyone in the audience encountered a shoulder dystocia in their practice? Okay, so it looks like we're getting a lot of yeses in here, so that's good. Well, maybe not good that you encountered one, but good that you're in the right spot today. Just going to give a couple more seconds for responses to come through. Okay, so I'm going to go to the next slide. And Anna, I will now turn the program over to you.
Okay, thank you so much, Christine and Jessica and the PSA. And I just wanted to thank everybody for attending today's webinar. I can tell from the chat that this is a topic that many of you have experienced and are probably, really looking for some strategies to improve care in this area. So I appreciate everybody's time. Again, my name is Anna Thomas. I'm a patient safety advisor at ECRI and the Institute for Safe Medication Practices Patient Safety Organization. Of course, I want to tell you a little bit about our PSO. We just celebrated our 15th anniversary as an ARC-listed patient safety organization. And with that work, we've collected close to 6.5 million patient safety events. So that's including over 4.4 million adverse events, 880,000 near misses, and 1.2 million reports of unsafe conditions. But of course, we talk about those big numbers and we want to talk about what's behind, those numbers, and those are people, right? So those are patients and family members, friends and neighbors, and these are all people that have been, experienced an event or experienced unintentional harm within our health systems. And so I really appreciate the opportunity to partner with the PSA to help to take a deeper dive into one of these patient safety issues. So I want to talk a little bit about our safe table that we held related to shoulder dystocia. So the Pennsylvania Patient Safety Authority partnered with ECRI and the ISMP PSO to help facilitate a statewide learning system to improve patient safety. And one way that we can do this is to conduct a safe table. So Safe Table is a protected environment in which Pennsylvania healthcare professionals can have an opportunity to discuss risk factors, challenges, mitigation strategies, and this was specific to those associated with shoulder dystocia. In this Safe Table that was held, an interdisciplinary group that included physicians, nurse midwife providers, nurses, safety team members, from various hospitals and birthing centers across the state engaged in a lively and facilitated discussion within this protected environment. Some key learnings from this Safe Table and also incorporated into with a review of current literature and also data from the PA Patient Safety Authority informed this learning systems approach that we use to identify shoulder dystocia related challenges, contributing factors, and then eventually mitigation strategies. So when we talk about the learning system informed approach to problem solving, we are working to effectively understand where vulnerabilities lie. Organizations that are doing this type of work, they need to examine all elements of the system. So this would be people, organizations, tasks and processes, tools, technology, and the physical environment. And you can see on this slide how we define each of those elements of the system, and we'll work some of these in as we go through the presentation. Issues in neonatal safety, they could represent a failure in at least one of these systems related areas, but in fact, many overlap and you can find causes within multiple areas. So supporting this concept around total system safety focuses on creating a greater efficiency and resilience in clinical and safety operations. It incorporates principles of human factors, systems design engineering, health equity, and advanced safety science to redesign individual components of systems to be more transparent and aligned, which would lead to safer and more effective care. So with that, that brings me to my first polling question. In your experience, what has contributed to shoulder dystocia within these factors that we just looked at? Are you seeing challenges with doing drills, challenges with staff turnover, or perhaps new clinicians? And feel free to put that into the chat. So I see staff turnover, new clinicians, drill, participation, a lot of comments around, okay, communication, experience, staff turnover, new staff, okay. participation in drills, new staff, sim drills, experience. This is great. So what we're seeing in the chat is very much what we saw in the safe table and what we sort of focused a lot of our research, or our research into, as far as thinking about some strategies. So I'm happy to see that we're on target here. Miscommunication, yeah, I'm sure that's a really big one too. So again, we use the safety table to help identify from the voice of the front line, what are the challenges related to shoulder dystocia? And very similar to what we see in the chat, we found 5 main categories. And we were able to identify some of those trends and challenges related to each of those categories for managing shoulder dystocia. So the first one is the reliability of risk factors. We had, one person that noted that risk factors don't necessarily always match up with every time you see a shoulder dystocia event, and that it's important to pay attention to signs to recognize a shoulder dystocia at that very moment. A big theme there was that early and appropriate recognition and response are essential factors of shoulder dystocia management. We also found that, again, drills and simulation, which I see a lot of about in the chat around that area. So one participant noted that their organization is required to complete shoulder dystocia drills for accreditation. However, the effectiveness of those simulations is really limited by the availability of training equipment. And I also saw in the chat, provider availability. Although it's possible to rehearse communication, time management, and requests for help, it can be really difficult to practice the necessary hands-on skills on a mannequin. It's not the same as a real life situation. Another area was patient preferences. So one person, mentioned that at their birth center, providing guidance to patients as they're deciding on the place of birth can be really challenging, especially given the unreliability of shoulder dystocia risk factors. And it was noted that it can be difficult to balance safety and patient preferences when considering whether an infant should be delivered at a hospital or a birthing center. Another big area was around debriefing. So ensuring that shoulder dystocia events are discussed and analyzed, this can really pose a challenge for teams. It was explained that some teams may complete a debrief more frequently when the labor and delivery does not go as planned, and less frequently when all goes well. So they're missing that opportunity to actually learn from what does go well. And inconsistent debriefing can also, really lead to missed opportunities for learning and improvement. It was also reported that some teams experienced discrepancies between provider and nurse documentation following shoulder dystocia events. One way that they were working to address this was to implement a formal postpartum debrief process that occurred after every birth. So again, whether the birth goes well or whether there's complications, to ensure that the whole team was on the same page regarding that delivery. And specifically, if an adverse event did occur or something unexpected did occur, the team would participate in more in-depth discussions. And then around reporting and legal concerns, some expressed that differences in definitions of what constitutes a shoulder dystocia event can make it difficult to know the condition's true prevalence. That may contribute to underreporting. And noted that it's, that it's necessary to standardize the definition of shoulder dystocia for both clinicians and safety teams to ensure accurate reporting. And lastly, there is an unfortunate concern among some providers around the threat of litigation when a shoulder dystocia event occurs, and that can potentially impact clinical care decisions and contribute to discrepancies, especially in documentation. So we heard about some of the challenges, and of course, it's always much more fun to talk about some mitigation strategies. So the next piece of the SAFE table was a brainstorming session where we discussed some mitigation strategies, and we really talked about how we can look at strategies within each of these 6 identified system elements. So I know I introduced this on a previous slide, but I did want to provide some definitions as people are thinking about different mitigation strategies and what might make sense to them and to their organization. So the physical environment, this is the work environment in which team members provide care and serve patients. Tasks and processes, these are the steps used to conduct safe and effective patient care and service delivery. Tools and technology, this is the use of technology and devices to create efficiencies and improve better outcomes. Organization, these would be the other factors that can impact care delivery and that safe environment for team members. People are the team members, the patients, the families, the caregivers involved in all aspects of the patient care experience. And then the external environment, which is, an aligned internal environment supports better integration with external factors. So within this conversation around these 6 system elements and potential mitigation strategies, we found 3 main categories of mitigation strategies. And this was really looking at risk assessments, simulation trainings, and then debriefing and documentation. So we know that there's a bit of a lack of consensus in the literature regarding risk assessments for shoulder dystocia, and this really poses a challenge to organizations where deliveries occur. A collaborative approach that involves clinical, patient safety, and quality teams needs to be used to develop risk assessments that includes reviewing an organization's shoulder dystocia data to identify trends in contributing factors. So some suggestions from the literature around standardizing shoulder dystocia risk assessment design would be to use an approach that examines multiple correlating variables. So think about some factors such as history. This would be your prior shoulder dystocia or brachial plexus injury, including antepartum factors such as macrosomia, gestational diabetes, or if there was a significant weight gain. Intrapartum factors, including cephalopelvic disproportion, protracted active labor, cessation of dilation, prolonged deceleration, cessation of fetal descent, or use of instruments for delivery, and then additional risks that can for poor maternal or neonatal outcomes, and those might include short maternal stature, pre-gestational diabetes, previous use of vacuum for delivery, Wood's screw maneuver, and fetal macrosomia. And of course, we talked about technology as one of the important systems. So as technology, or elements of a system, excuse me. So as technology becomes available, we want to think about appraising machine learning models that uses data gleaned from the electronic health record to offer better predictive value than the traditional risk assessments. We can also use risk assessment results to inform how the organization can standardize criteria for delivering at a standalone birth center versus a hospital, and also engaging patients in discussions about the potential risks of delivering in that type of setting. And then educate all clinical team members on risks of shoulder dystocia and validate that they're confident in delivering in different positions. So that would include using appropriate equipment needed to move and reposition patients, such as pull bars or birthing balls. So I saw a lot about simulation and training in the chat, and that's something that we discussed a lot at this safe table too. So we found that an interprofessional training curriculum that incorporates simulation ranging from low fidelity to high fidelity equipment improves clinical and technical skills and can positively impact both injury and claims rates. Shoulder dystocia simulation training should definitely include a multidisciplinary team. So this might include an attending provider, medical residents, nursing, other clinicians. Clinical educators can utilize mannequins or other simulators for training and validate those clinical and technical skills in simulation scenarios. And it's important that we think about designing and implementing drills that really focus on teamwork and communication related to the recognition of potential risks to the birth parent and the neonate, the escalation and effective communication to a response team using a validated method, the use of checklists and protocols, incorporation of different communication protocols such as SBAR or CUS communication, and then scenarios, again, involving patient and family engagement. That's an important thing to be built into a simulation training scenario. And then you want to think about how to maximize the opportunity to learn from the debrief that occurs after each simulation encounter, and leverage advanced technology such as virtual reality for training scenarios, which has been shown to reduce time from recognition to delivery of a shoulder dystocia. And the third major area that we looked at as mitigation strategies were around debriefing and documentation. So these components are key to both providing a clear record of the event and offering a mechanism for the team to evaluate the effectiveness of their response. A standardized format to capture pertinent details of the event allows analysis and feedback to occur. And again, we found that this was really important, that it happened after every event, every birth or every event, whether the outcome was favorable or not. Clinical leaders can provide actionable feedback to clinicians on shoulder dystocia response, including how they performed individually and as a team. You might consider using technology such as video recording of the shoulder dystocia response that can be used to enhance feedback and identify areas of improvement. And think about the design of documentation tools that use a standardized form, and that would include which team members were at the birth, what their role was, what time did they arrive, how much time did they spend, which shoulder was involved, what delivery maneuvers were attempted, the order of use, the time of each attempt, and the time until successful repositioning. What was the estimated blood loss, the assessment of the birth canal, APGAR scores, umbilical cord pH, and the assessment of the neonate. And then we can evaluate the electronic health records capabilities for improved record sharing between facilities and standardized phrases for documentation. We can think about implementing a standardized debrief process that's led by a patient safety liaison, or nursing leadership, or a maternal fetal medicine specialist. And again, we've mentioned this a few times, but debriefing after every birth, highlighting what went well and what did not. And the big key with this is ensuring that psychologically safe environment that encourages staff to share feedback. And also promoting physician and anesthesiologist participation in debriefs, depending on who was involved in the response. Debrief forms should include a review of communication, timing of recognition, response, and mitigation, knowing what went well and what could be improved. And clinical leaders can use this to compare documentation with notes from the debrief and address any potential discrepancies. And we want to think about including the birth parent in the debrief and the family, and highlighting that the shoulder dystocia is now really a key part of their medical history that needs to be shared in any subsequent pregnancies. We can think about measuring and monitoring compliance with debriefs and include this as a departmental performance improvement metric. And lastly, identify a liaison between the clinical team and the patient safety team. And that person can participate in debriefs and facilitate inclusion of clinical team members in any case review or causal analysis. So that brings us to our next polling question. Does your organization have a standardized debrief after every delivery? And I'm seeing yeses and nos. Seeing more no's than yeses. So that's helpful, because that, only after events. Somebody said it's available, but not always used. Supposed to, but doesn't always happen, not consistent. Only with dystocias. Okay, so I'm seeing a lot of variation in responses in the chat. I'm seeing a lot of people saying that no, they're not using a standardized debrief form, or that it may exist but not being done consistently. We have one person saying we call it summation of delivery. This allows nursing and providers and the patient to all be on the same page. Exactly. Yes, that's exactly the goal there. But it looks like from reading the chat responses that this is an area that there could be some takeaways and some work being done to improve on that debriefing, consistent use of a standardized debriefing form. So the last piece of this is thinking about people and patient factors. And I'm sure we've all been talking a lot about patient and family engagement, and it's, the incorporation of patients and families into patient safety can be difficult, but is definitely necessary. So when we're talking about, our environmental components, our system components, we have to really think about people patient factors, right? And this includes patient and family engagement. How engaged has the patient and the family been during the prenatal period? Have they been able to communicate important facts such as past medical history, right? We just talked about that, including them in the debrief, and how they do need to be aware now if they've experienced a shoulder dystocia or another complication, that they have to be a part of communicating that as they move through various care transitions. And then social drivers of health. Of course, the list of these is huge, but some examples are what access to care the patient has had, prior to coming in for their delivery. What barriers did they face in just having their basic healthcare needs met? Health equity. We like to ask, are we capturing data related to health equity when we debrief or do an RCA? So when you have, part of your debrief process or any causal analysis that you're doing after a shoulder dystocia event, are you looking at it through a health equity lens and capturing some of that data related to health equity and starting to look for trends in that area? And then patient preferences. Did that impact maybe where the patient delivered, what type of positioning they were using, other interventions, and was that included in the care plan or impact the plan of care? So something to think about, as we're doing this work, is including that people patient factors. And I'm wondering if anybody would be willing to put some other people patient factors into the chat. No prenatal care, culture of safety, absolutely. And that's for, patients, families, and staff, lack of knowledge. English may not be somebody's first language, right? And what is the availability of translators? Language barriers are huge, especially in the time of, in the time of emergency, lack of prenatal care. Yes, I'm seeing a lot around English as a second language and language barriers during emergency. So that might be something, to think about building in to the risk assessment or to, any type of response, or even the simulation. How are you managing that? Home deliveries that have complications. Requests for vaginal deliveries despite risk counseling. So these are all really good points, and this isn't it. One of the things that makes this a challenging situation is that it's not just one patient, right? When it's a maternal health patient, you're often taking care of, the pregnant person, but also the family, the potential partner, the potential neonate. So there's a lot to take into consideration there. Somebody said that financial resource strain may cause patients to miss appointments. It prevents them from getting medications. Intimate partner violence, that's a huge one. They're all a factor. It may lead to poor prenatal care and no access to ultrasounds. And that's a really important point, because your risk assessment is only, going to be is only going to be able to capture information that is maybe gained at some of that during that prenatal care period. And if they're not receiving adequate prenatal care, it's going to increase the chance that some of those risks are not identified. So those were great. I really appreciate everybody's chat responses there. So I always have to, I come from doing a lot of work in causal analysis, and anytime that we talk about mitigation strategies, and these are, specific today for shoulder dystocia, we have to talk about sustainability and sort of the action strength hierarchy. I have two models here of sustainability. So the one on the left was developed by my colleagues at the Institute for Safe Medication Practices. And then the one on the right, it talks about, another sustainability model and increasing effectiveness with higher strength or higher leverage actions. We can see that the more effective the level of risk reduction is, the more sustainable the implemented action is going to be. So I always encourage people to keep these models such as these in mind as you're thinking of change ideas. And note that finding and implementing high leverage action items, specifically around shoulder dystocia, that might be really challenging, right? We've talked about a lot of challenges during this webinar around shoulder dystocia, and that goes, up from system factors to staffing issues to people and patient factors. So it could be very challenging to find high leverage action items. And many of the strategies that we discussed today, such as standardizing risk assessments, debriefing, things like that, they may fall more into a medium leverage category, and that's okay. The important thing is that we're not relying solely on low leverage strategies, such as, education, reminders, be more careful next time, hanging signs, things like that. We want to do everything that we can to have to find strategies that are as high on these models as possible, that focus more on systems changing, and will have more of a likelihood that they will help to address some of these issues. So with that, I'm going to turn it over back to Jessica.
Thank you very much, Christine and Anna, for that presentation. I did see one question come in during Christine's portion of the presentation, so I'll go ahead and share that now. The question is, how did you determine lack of association between shoulder dystocia and labor delivery events or patient demographics?
Thank you, Jessica. So the way that we did this is we looked at the number of shoulder dystocia events in each grouping under a category. So for example, maternal age was grouped into 5 categories, and we compared the just number of women in each age group in our data set, and then the number of shoulder dystocia events that occurred in those age groups. And the distribution of shoulder dystocia events in age group was similar to the distribution of age group itself. So we didn't find any meaningful association, for example, of an older versus a younger mother.
Thank you, Christine. Any other questions, please feel free to put them in the chat box. I have another question here. What are some strategies for engaging frontline staff in improvement efforts related to shoulder dystocia?
Thank you. I can take that question. That's a really good one, especially because we saw in the chat that's one of the issues that people are facing, is just a lot of newer staff, a lot of staff turnover, expertise understaffing is something that we like to talk about. So it is really important that we have frontline staff involvement in any improvement efforts, and especially those that we've talked about today. So one way would be to encourage patient safety event reporting, and that would be, encouraging frontline staff to report those events, but then also getting back to them, including them in any improvement efforts, including them in any strategies, and letting them know sort of what work is being done to mitigate the issue that they've reported. If you have not already, it's always a best practice to have a good catch program, so that if your staff are reporting, good catches, they prevented something from happening, they are getting rewarded for doing that. It can be challenging, but it's also a best practice to include staff in your causal analyses. So, thinking of a way to include them in the RCA process, and usually that would be maybe not necessarily the person involved in the event, but a peer that can contribute to the RCA. And then again, bringing any actions or strategies for improvement back to the staff. And the big thing is really allowing them that input and allowing them to comment on any improvement planning, because a big barrier is when something happens and then there's new rules, a new education, a new warning, and the staff didn't really have that opportunity to comment and to share whether or not it would, provide any input on feasibility. So I think those would be some of the main strategies.
Thank you. Another question came in about debrief forms. Should debrief forms be a part of the ERM? If so, are they discoverable in litigation?
So that is a very good question, and is likely going to be dependent on your organization and your organization policies, and should always kind of be run through your own sort of risk management or legal team. The general, and again, I can speak from patient safety organization world, where we have this protected environment under the PSQIA, where it's things that are done to improve patient safety generally are considered to be patient safety work product, but that's not going to be the answer for everybody that's attending today. So I encourage you to discuss that internally.
All right, we have another question here. What labor and delivery events did you look at to determine association with shoulder dystocia? I think, Christine, that might be for you.
Question. So the labor and delivery events other than shoulder dystocia were fetal distress, the presence of meconium stained fluids, nuchal cord, breech presentation, hypoxic conditions. We also had other, and there were 21 event reports where we were not able to identify any of the labor and delivery events listed, or any labor and delivery events, excuse me, that we were looking at.
Thanks, Christine.
Yep.
Another question we have, what are some strategies for disseminating lessons learned? Maybe for Anna?
Yeah, absolutely. And this is a really important aspect of any improvement efforts. So we talked a lot about debriefing and using the debriefing process to learn to get insights, and then you would want to disseminate from that. You may consider something like tiered huddles. So if there is a huddle that happens maybe in the unit where the event occurred, and then some of that information is brought up the chain, so to speak, in that tiered huddle process, that's really helpful. And we always like to talk about, in patient safety, we like to talk about storytelling because it is really impactful. So thinking about, ways to share de-identified stories of some of these events in a way that is, that people are able to learn from, especially if it's potential that it could occur in another care area, or there's something that, that really, something that came out of it that's a strategy that will be beneficial outside of that area where that event happened. Storytelling is a really helpful way to get that message.
Great, thank you, Anna.
Sure.
Another question that came in the chat box, they said, we encounter many patients with birth plans and an unwillingness to deviate from their plan. Any data on the most effective way to effectively communicate risk when the patient is identified as high risk?
That's an excellent question. I cannot speak to a specific, to specific data. I'm sure that it's out there. As far as effectively communicating risk when the patient is identified as high risk, I think the big thing that would be helpful here is if you have that standardized risk assessment, like we talked about, that, and you can include the family and sort of work on that patient and family engagement in them understanding that risk and understanding, where these are the 10 things, these are the 10 things that we identified, and this is what makes you high risk. And hopefully that will help them to understand that it's not just somebody telling them that they can't do, the thing that was really important for them to do. So I think patient and family engagement is another one of these topics that we have to think about incorporating it in every step of the way when we're building, when we're looking at patient safety and when we're looking at improvements.
Sure, that makes sense. We have another question in the chat box. What labor and delivery events did you look at to determine association with shoulder dystocia? Christine, are you able to take that one?
Yes, I can take that one. So as I said before, we did have 8 labor and delivery events that we identified from PACER's reports as well as the supplemental data forms. And there were others. Shoulder dystocia was one event that we identified. Others included fetal distress, meconium stained fluids, nuchal cord, breech presentation, hypoxic condition, and then there was a category for other event or unknown. We did look at if shoulder dystocia, was occurring with any of these other events. We did allow for an event report to be coded for multiple events. So for example, if there were meconium stained fluids and a shoulder dystocia, they would both have been coded for that event report. And we did not find any significant associations or meaningful associations with shoulder dystocia and any of the other events listed.
Thank you, Christine. We have another question here. How can we best support staff who are involved in a shoulder dystocia event?
Thank you. That's such a good question. So I think the first way to support staff that are involved in a shoulder dystocia event is to really think about the environment and making sure that that they have that psychologically safe environment. So that is both as far as any event reporting, but also in sort of that debriefing period after an event, and providing support to them after that. One way that you can do that is to have a peer support program. And that might be something, that you already have or can consider having within your organization. And that would include volunteers that are trained in something called psychological first aid. So they would be a peer, like a peer that has this training and can come and provide that support to a staff involved in an event. And then again, circling back to what we talked about with engaging frontline staff, it's really about including them in any improvement efforts. helping them to identify system issues, and letting them know what's being done to fix any problems that were identified.
Thanks, Anna. We just got another question in the chat box. Has PSA made any recommendations to hospitals or health systems in light of its findings? If so, what?
So I'm not sure if somebody from PSA prefers to answer that one.
Yeah, I can speak a little bit to that. We did publish the final report, which includes all of the other events and outcomes that we reported on, not just shoulder dystocia, and there will be more communication coming in the future from PSA on this topic.
Thank you, Christine. The webinar will be ending soon, but we do have time for a few more questions before we end. So please pop them in the chat box. I do have another one here. How can we learn from shoulder dystocia responses that go really well or have a good outcome?
I love that question, and I think it's a good one because we saw in the chat that when we were asking about debriefing, that it's not really happening consistently, and that it's especially not happening, or that it's only really happening when things don't go so well. But we can learn a lot from shoulder dystocia responses that are smooth and that go well and have a good outcome. I've seen some interesting literature lately on success cause analysis. So that's sort of following the same format as a root cause analysis, but you're looking at events that sort of should not have gone well, but did, and really learning, what happened, what contributed to that success. And then again, you can take that information and disseminate it. Like we talked about debriefing, even when things go well, because again, you can learn from that, learn from what went well, ask questions, ask people why they made the decisions that they did, or identify communication strategies that really worked. And then disseminating lessons learned in the same way that you would less favorable outcomes. So part of this is celebrating, right? Like we talked about good catch programs, but we want to celebrate when we did, when it does go well and when we had an excellent team effort and we got a good outcome. That's just as worth sharing as when things don't go as well. And all of those things can be seen as opportunities for learning either way.
Thank you, Anna. I want to thank everyone for joining us today, for our presenters, Christine and Anna. We appreciate all of the important information you shared. If you experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any questions to Shelley Mixel at shmixell@pa.gov. This concludes our webinar. Thank you all for attending.